Good morning, everyone. Thank you for being here. I'm going to start by asking as many of you that want to move up closer. We got this huge room, but we're kind of a more smaller group, and we're going to have a panel discussion. So if you feel like moving up or being closer to the mic, that would be awesome. And we have to start every session with our housekeeping notes, and I'm sorry, you've probably heard, most of you have heard them many times. So I'm going to just thank you for your contribution to the 2026 ABRF annual meeting and remind you to please silence your phones if you haven't already, that photography of ABRF meeting sessions is permitted, subject to speaker's request, not to capture pre-publication information. You're okay with any of your slides? Okay, yes. We encourage you to take pictures of the slides that we have. And then there is a recording of the program sessions will be available on the meeting website following the annual meeting. And then the ABR social media policy is that everything can be shared. If the speaker asks that it's not shared, please do not post it. And the hashtag for the event is hashtag ABRF 2026. And then this is a panel discussion, so please ask questions anytime, get up, and you will also receive an overall meeting evaluation following the meeting to help improve the ABRF meeting experience. So we would love to have you provide feedback for the session in the app and look for the evaluate the session link within the, it says look for the evaluate this session link within the session on the app. Okay, so thank you for putting up with the housekeeping. And I just want to just set a stage for what we're doing today. So this is following our excellent session on animal welfare regulations and the ongoing push to reduce animal use. We're reminded of our responsibility to uphold the 3 R's: replacement, reduction, and refinement. So this session focuses more on reduction and refinement, especially how we might look at how we can design our experiments efficiently for maximum understanding. And so today's panel, we have Dr. Ingrid Bergen and Dr. Kent Lloyd, and we're going to each introduce ourselves. I will give a few questions to them to start it off, and I hope, again, that you will join in and ask questions. So my name is Jennifer Koblinsky, and I am at Virginia Commonwealth University and Massey Comprehensive Cancer Center. And I was pulled into the role of cores to establish a cancer mouse models core about 10 years ago. And we also added histology pathology into that core. And later that got split off so that I also am scientific director of our biorepository and histopathology core. So kind of seeing the whole landscape of how we do this, from getting tissues to make PDXs, and growing those from both cores. They do connect well together, to then having our animal experiments go through and have histology analysis. And I'm constantly looking for pathologists to help us with these studies. And I ran into Ingrid at one of these ABRF meetings, and I call her and her colleagues unicorns, because any institute that I've been at, we have not had them. I know some of you, like UNC is hogging them all. They have like 4. They could send a few up the road, but anyway, I'm just joking. So it's really great to have that perspective. And Kent, I've known for a long time. If any of you are in the cancer field, I'll give one quick plug. We have a preclinical cancer models consortium that if you're interested, please see me. That we have a group that meets monthly via Zoom to talk about how we do these animal experiments related to the cancer field, and Kent's joined that and has been very valuable. So anyway, I'll let you each introduce yourself. Thank you.
All right. Can you hear me okay? I am Ingrid Bergen. I am a faculty member in the Unit for Lab Animal Medicine at the University of Michigan in Ann Arbor. And also within the unit, I'm the program director for our ULM Pathology Core, which is a shared resource facility. And we provide histopathology, clinical pathology, which is pathology related to body fluids, like hematology, clinical chemistry, and pathology services to investigators at the University of Michigan and external institutions. So really briefly, I've been at the university since the end of 2008. I was trained as a veterinarian. I got my veterinary degree from Pennsylvania. So I have the backwards veterinary degrees, VMD, same thing, it's just a pen thing. But I'm trained as a veterinarian. After veterinary school, I went to MIT, where I got a master's degree in toxicology, but also did lab animal training. So in my first life, I was a lab animal vet, so I'm board certified in lab animal medicine. But my project there was very pathology oriented. So then I realized my true love was pathology. But I went walkabout for a bit and did some time in private practice, but eventually returned to academia and did a pathology residency. So I am boarded in veterinary pathology from Michigan State. And as I said, I've been at University of Michigan since 2008. Our core facility has existed. We've always had pathology service, but our core facility has existed since 2013. And I've been director since 2020. So, it about me for now.
All right, good morning, everyone. My name is Kent Lloyd. I'm not a pathologist. I am a veterinarian. I was trained as a surgeon. But then I also did my PhD in physiology, and now I'm doing mouse genetics. I'm a professor of surgery at the University of California, Davis, associate director of our cancer center, and director of our mouse biology program, which has been operating for now 26 years. And just this past year, we opened a NAMS testing center.
Okay. This is a problem using your phone for your notes. Okay. So my first question is for you, Ingrid, and how do you define comparative pathology, and why is it essential for interpreting animal models?
Okay, it's kind of a big question. I think because of my practice setting in biomedical research, I think when many people think of pathology, they think someone looking through a scope, which I do look through scopes, and coming up with a diagnosis. And particularly, we think of it in the context of clinical medicine, be it human or veterinary, that you're coming up with a diagnosis for a particular patient, or be it animal or human. But I think broadly about it, and I think comparative pathology is pathology focused on the basic biomedicine or the basic pathobiology behind a model. So whether it is looking at a histologic slide, whether it's evaluating an animal model, or more broadly, whether you're talking about design of a study, or you're thinking about a non-animal alternative model in the context of the disease, all of that is, in my view, comparative pathology. Because pathology at its root is the study of disease, and whether you're looking at that at a microscopic level, a molecular level, whatever your model system is, you're basically looking at whatever model it is, thinking about the underlying pathobiology and comparing that to the pathobiology of the disease process or the basic biologic process that you're trying to understand. So I think of pathology pretty broadly. That might be unique or somewhat specific to my practice setting, but I think it's a very useful way for any scientist to think. And I think, we'll get into it, but some of the pitfalls that we see in the use of animal models relate to a failure to kind of tie the model back to that basic biology. You're just like, this is what happened in the animal, so this is what's going to happen in the human. I think that's too simplistic, and you have to look more at the process. So I think it goes back to the process.
Great, thank you. And Kent, how do you feel that mouse cores that do not have veterinary comparative pathologists can make sure they are setting up their experiments for the best results?
Well, that's a good question. So my feeling is probably that most cores don't have a veterinary pathologist or a comparative pathologist, which I think is very important, the distinction between veterinary pathology, human pathology, and comparative pathology. I think there's distinctions between those three. So when I speak to, as a core director, when I speak to a client and we go through their project, of course I always advise, speak to a statistician for power analysis and so on, but I also remind them that if their project warrants it, based on the description, I also tell them to speak upfront with a pathologist, preferably a comparative pathologist, if they can find one, if there's one available, because in my mind, there's too few right now available in the world today, and they're really necessary. So I think it's important for an investigator to work with a pathologist, if they aren't already one, and most likely they are not going to be one, but work with a comparative pathologist. I'll help them find one. It's the kind of field where they don't have to be actually on site. You can work with them off-site and network. And oftentimes what I hear back are comments like, well, I'll bring a pathologist in at the end once we, get all our other studies done, and then we'll get some confirmatory evidence with the pathologist. But I think that's a mistake. I think the parapathologist needs to be brought in the beginning to help plan the analysis, and not only to provide a confirmatory diagnosis. I think the project works much better that way. So that's what I would recommend.
Great, thank you. And then related to that, Ingrid, like what key study designs and elements do you feel are most overlooked when these pathology endpoints are involved? Like Kent mentioned, we tend to bring you in at the end, and instead, how can you discuss that?
Yeah, that's actually a really big question. Could probably just spend the whole hour on it, but let me think where I want to go with it. I think at its most fundamental, so if you're talking about traditional pathology, like from a microscopy standpoint, I have a slide that I use with my students, which I facetiously call all of pathology in one slide. And it's the idea that pathobiology is a process, and there's always a molecular antecedent, like something happens that's molecular or biophysical, and then the morphologic change, the change in the tissue, is always downstream of that. So one thing I always talk to scientists about is, the question I ask all day, every day, to every scientist is, what is the question you're trying to answer? Because depending on what is the goal of the study and the timing of the study, traditional pathology, like microscopy, might not be the ideal readout to answer the question. So I think, as with anything in science, you always have to match the question you're trying to answer with both the timing of the endpoint and the ideal mechanism or the ideal method to answer that question. And in pathology, the other thing to remember is that it's a process even within the morphology, because all of pathology can basically be understood as tissue injury, body response, and repair or resolution. So there's some sort of injury, be it a molecular change as in a neoplasm or a toxic change or something like that. Then there's a body response, which is usually an inflammatory response, which is a cleanup response. And then there's a resolution, which could be regeneration, it could be repair by fibrosis. But that simple process, I mean, that's my joke slide for my students, that's all of pathology in one slide. And when I teach a class, which is basically like pathology for the non-pathologist, to toxicology students in the School of Public Health, and essentially all of the paths that we cover, you can kind of follow that process. So for investigators, I think one of the problems that we see in animal models with translatability or even within a study is sort of the time point at which you're looking. Like, what would you expect to see in the tissues? Should I be looking at the tissues? Should I be looking at a molecular event rather than a morphologic event? And understanding, like when I was in veterinary school, I said that the one thing I didn't want to do, famous last words, was go into pathology, because I thought, like, I don't understand how they do it. There's all these different diseases, and they have to remember the pathology for each one. I think there's a misconception that every disease has sort of one characteristic pathology, and it's sort of like a one-to-one correspondence. But really, almost all of it can be understood as that progression for the body to have an injury, to respond to it, and to resolve it. And when you think about it like that, it really helps you with the interpretation of your experiment, because you're not comparing sort of apples to oranges. You're not saying, well, in this condition, there's inflammation. In this condition, there's scarring. You're looking at it as part of that process and responding to the initial injury. And that comes up time and time again when I talk to investigators about the results of their project and trying to place it in that context. So understanding what the question is you're trying to answer, what is the appropriate modality to answer that question, and what is the time point in which I'm interested in when I'm looking at that question.
That's really interesting. Yeah, because like cancer fits into that whole thing as, yeah, an injury, right? That's changing. And so I think that's another part that some of us don't think about is like each disease is so different, but you have that broader view of it all. So Kent, you mentioned about you can help guide investigators, to the right pathologist. Do you feel like most people are coming to you after the fact because they come in and say, oh, I have this unexpected result? And then how do you guide them around that to maybe, if they decide they want, and that's what we want to stop is this redesigning, but if they have to redesign an experiment too?
Yeah. Yeah, another good question. So again, that's why I think it's important to bring in a pathologist early on in the project and not at the end. When it comes to, whenever I advise a client, and I listen to what they have to say and what they're intending to do, I really try to look at them not as just a service provider, but really being a partner in the research. I mean, that sounds a little kumbaya, I know, but what I'm getting at is that the more I engage in their project planning from the beginning, the less problems I'm going to have at the end. Because oftentimes, they will discover something that they weren't expecting. So what I tell people in the beginning is expect the unexpected, and don't be surprised, and that those unexpected findings are opportunities. So depending on what the outcomes are, that will guide me into terms of finding them another expert. I mean, as you hear from this conversation up here, and as I know you know, that you can't know everything. And there's so many different technologies and so much depth of knowledge in various fields that are really essential in order to interpret the findings on an animal model being used in an experiment, that it's just impossible to do all these things on your own. So it's really, really important. I do encourage investigators who are trying to, go it alone, or especially a clinician scientist who may not have a, PhD level scientist in their laboratory doing the daily laboratory work while they're out seeing patients, is to really establish a network. And that's what I try to do, is I try to be that middleman to help find them, because I have a network of people I know around the country, around the world, that I can help them connect with, depending on the results of their experiment. Does that help what you were asking?
Yeah, that's great. Okay, so I'm going to ask you both thoughts. So if you can each share an example where understanding model limitations changed the direction or interpretation of a study. I'm sure you both have some good stories about that.
Trying to think of a good example. I guess, well, I don't know if this is exactly what you're getting at, but I can think of, aspects of the model that changed the interpretation of the study. So this might not be, well, I'll try it and then we can think of other examples. So I work with a group who studies human vascular disorders. They work with genetic databases for people who have connective tissue disorders. So they have abnormalities in collagen, things like that can affect the vascular system. And one of the things that they've tried to model, there's a disease in humans called vascular fibrodysplasia. Dysplasia just means altered form or altered appearance, altered morphology. And this is a disease that predominantly affects women, usually women who are relatively young in their 20s and 30s, and they develop essentially scarring, which is collagen, scar tissue, in the walls of their blood vessels, which, as you can imagine, it's a blood vessel, it needs to be elastic. If you have scarring, it makes it less elastic, and then if there's enough stress, potentially you could have a catastrophic rupture of the vessel. So it's basically the fibrodysplasia is the abnormal fibrous scar tissue in the wall of the vessel. So this is kind of a horrible disease and very difficult to study in humans, kind of a ticking time bomb. So they've put these genetic mutations that underlie the disorder into mice. And there's been a lot of effort into finding a mouse model for this disorder. But basically, people were looking at it as trying to have sort of a one-to-one correspondence. Like, look at the vessel, does it have scarring, does it have collagen? If not, not a good model. But going back to the idea that pathology is a continuum, we started looking at some of our mouse models at early time points. And one of the concerns about this disease is, or the idiosyncrasies, is that it's female predominant. But if you look at the genetics, humans with the disorder tend to have male relatives with a higher incidence of aneurysm. One of the problems with the human disease is we don't just go pulling arteries out of people for the heck of it. You can't really biopsy it. You can, but it's really difficult to biopsy an artery. So in the human disease, we're always looking at the aftermath of everything that happened before. And what we found in our mouse model, in the female mice, early on in the disease process, they were getting not scarring, not fibrosis, but these gaps in the wall of the artery where the smooth muscle cells had degenerated, the elastin was having increased breaks. So if you look at it just a strict one-to-one, is this collagen? No, therefore bad. What was really happening was there was a degenerative process. So the primary process in that disease is really degeneration. But there was a sex difference where both mice, male and female, get degeneration in the wall of the artery. The females have a greater ability to mobilize genes related to extracellular matrix remodeling. So they, once they have degeneration, get very busy and make all this scarring as a repair process for that. The males, like when we did our single cell and our spatial biology, the males don't have that as much of an ability to activate the extracellular matrix repair genes, so their arteries just rupture and they die. So that was an interesting sex difference, and it has a really important clinical correlate, because most of the clinical interventions and like some of the drug studies and things like that in human medicine were focused at disrupting the scarring, because you don't want that hardening of the arteries, you don't want that like loss of elasticity. But think about that disease process. If the scarring is a rescue mechanism to preserve the artery, and you're trying to chemically intervene with that scarring, you think you're making it better, but what you're actually doing is impairing. That's a rescue mechanism by the animal's body to try to preserve that artery. And although it's not the native artery, it's better than rupturing and dying. So it really entirely refocused our consideration of the disease, and what was kind of a limitation, oh, well, the mice don't get scarring in the walls of their vessels. It really was a fault of not understanding the pathobiology of the entire model, and by be able to look at the animal model at a time point where we just don't have access to the human tissue, which is early in disease, because we're not going to pull early arteries out of people. It really revolutionized our understanding of the disease process and where we should be looking. We should be looking early on at what's happening to cause those degenerations when we think about how to treat the human model. So I love working with that group, because you can really see how, I love having that human aspect and being able to kind of interpret the animal model in the big picture of the disease, rather than just looking at a slide and going, yes, no. So, comparative pathology.
Yeah, that's really important and very awesome example. How about you, Kent? Do you have a good?
So I don't know have one as exciting as that one, but again, I think this reflects the fact that it's really important to have early conversations with investigators and plan the project. As a core director, I think it's important to admit what you don't know, and be very forthright with what you do know. So, for example, if I have an investigator coming to me and they want to do a hearing study, and they say, well, I'm going to use C57 black 6 mice, and I try to steer them away from that, because black 6 mice get presbycusis. They lose hearing with age, so that's not a good idea. I remember early on in the time when we were doing a lot of knockouts with embryonic stem cells at the time were derived from 129 substrains of mice. And these mice would sometimes have a corpus callosum defect, so a failure of crossing over the white fibers between the two hemispheres. And I remember in this one lab I was in a long time ago, I was called in to look at some slides and look at the animals, and here I am not a pathologist, but I was a veterinarian. So they said, well, he's a veterinarian, he must know all about this. So I took a look, and they said, this must be the cause of these mice were dying early on, so this must be the cause of death. So I had to let them know, it wasn't my project, but I had to let them know that 129 derived strains, the ES cells that are made from them, mice develop from them, oftentimes get an imperfectly penetrant defect in the corpus callosum. So if you use them for behavior studies, or in this case, there was a death, these animals were dying in this particular project, had nothing to do with the corpus callosum defect. And then another one is, again, going back to Black 6. Now, I'm also directing with a knockout mouse project at Davis. We're in our last year of that. And we all started using C57 Black 6N ES cells, which is another story because not related to your question, but that was an interesting story because we were wanting to derive embryonic stem cells from the Black 6 mouse because that's the common laboratory mouse everybody uses for studies, and they wanted to get away from 129s. They're poor breeders, low fecundity, and so on. So several of us, well, I guess I'm going to tell you the story anyway. Several of us were trying to develop these ES cells. Long story short, we all were selecting, we had selected ES cells not from the Black 6J colony, but from the Black 6N colony. So I was very embarrassed when we did a genetic analysis and turned out that my ES cells were Black 6N. So then they had some of the other groups do a genetic analysis on theirs too, and son of a gun, theirs weren't Black 6N too. So we all made the same mistake. So that saved face. The reason I'm bringing this up is because as part of the COM project, an eye exam, ophthalmologic exam was done, both anterior and posterior chamber. And it turns out that the Black 6N mice have the RD8 mutation that causes them retinal degeneration. So these are showing up as, you can explain this better than me, but show up as little yellow flecks in the background of the retina. And of course, we're looking at genetic changes which might cause retinal degeneration or blindness and so on. So those are some of the things that have caused us to, make shifts in our plans. When we look at something, we first go back and say, well, is this a imperfectly penetrant phenotype, or is this typical for this particular strain? Very, very important to know those relationships between, especially the wild type strain, and the phenotypic appearance.
Can I add on to that a little bit? I think in listening to your story about the B6, I had my own thing in the background, B6 recent experience. But I think it'd be great if you have someone on your team with expertise in every area, but nobody operates in that realm. And as Kent was saying, it can be hard to find someone at least to work closely on a day-to-day basis with your team. But I think it's important, as with any other field of science, when something unexpected happens, or if you're planning a study where pathology is a major readout, like if you're hanging your description of your genetically altered mice saying that it's a model of disease X based on the pathology, I think if you can engage or reach out to subject matter experts at those stages where the model's not behaving quite as it should, or I just want, at the beginning of the study, at the end of the study, I want some sort of confirmation that I'm interpreting the pathology appropriately. So a lot of the business that we get through our core are these, something weird is happening, it's not behaving as it should, can you help me? And we just recently had one from one of our researchers who studies the MASH models, like the metabolic associated steatohepatitis models, where they were trying to, there's lots of ways of inducing fat in the liver for these models, and they were trying a diet only, like a high fat only steatohepatitis model in B6 mice. And it was kind of erratic in their positive control, like high fat diet group. They were getting some animals that got steatosis, which is fat in the liver, some animals that didn't, kind of sporadic. But in any case, they got enough animals in their positive control group that had high fat and wanted us to do just severity scoring, just like comparison. There's standardized ways of doing it. But in looking at their mice, what I noticed in their diet-only group, yes, there were some animals with steatosis in the liver. Unfortunately, the animals in their positive control group that had that steatosis also corresponded perfectly with the absence of something, and that was that all of those animals lacked portal veins in the liver. So the portal vein, everyone remembers this, is the vein that brings the blood from the intestine to the liver. So it's the highway that brings the substrate blood for the liver to metabolize. And in humans, animals, and many species, you can get congenital abnormalities where that portal vein bypasses the liver. So that's a portosystemic shunt. So you can imagine that's a significant metabolic problem because your liver is not getting the opportunity both to withdraw nutrients and to metabolize toxins and other substances in the blood. So the blood goes direct to the bloodstream. There's lots of consequences. But in this study, the only animals that were developing steatohepatitis from their diet were the animals that had this background portosystemic shunt. And that, it turns out, it's a known thing. I mean, it's in the literature. It's probably not as known as it should be, but B6 mice do have a pretty high incidence of congenital portosystemic shunting. And so that's a major confounder for a liver study because the metabolism of those animals is completely altered. So what they were studying was not necessarily really completely diet-induced steatohepatitis in a normal mouse. They were studying steatohepatitis in a mouse that, in a subset of mice that had a predisposition for it because of this portosystemic shunting. And that is going to have implications for the brain. It's going to have implications for their animal's growth. It's going to have implications across the entirety of that model. So there, if something, like, if you're just looking at the fat, because they had like a nice image analysis way where you could just measure fat droplets, but the context is important because you could be measuring something that's either confounded or is not exactly the readout that you expect. So that was an example of if something weird or unexpected happens, like it's just not quite behaving, we're not getting the animals, sometimes there's another thing going on deeper in the biology that you need to be aware of if that's your model.
And I think this is a great example of, again, how you can refine your experiments by connecting with the right people to know these things before you even start it. So that can help us reduce our animal numbers because we don't have to repeat it. Yes. Yeah. Do any of you have questions? Yeah, please.
Hi all, great to hear your perspectives so far. It's very apparent, and same with my core facility, to try to get comparative pathologists in early on a study, maybe even before it's designed. But I was wondering if you employ any strategies to advertise this to make sure that clients are aware of this. I mean, we ourselves get people that have designed something, have bought thousands of dollars of reagents, they're like, please do this for us, and then they get results they don't expect. And you know, we really want to try making it aware that we have these resources at our institution. So is there anything that you do to kind of advertise that or push that out to make sure that these resources are getting used?
Okay, so as a profession of pathologists, we're bad at this. Here's one of mine. Did that work? Oh, I don't know. Oh, okay. So as a profession, we bear a lot of the blame for this. As veterinary pathologists, we're happy, we're talking to scientists, we're sitting in our office with our digital slides or our image or QPath or whatever we're doing. But just like in the last talk, outreach is also important because what is the good if you can't take your skill set to the people who need it? So the American College of Veterinary Pathologists is the board certifying entity for veterinary pathologists. And within that group, so that's all veterinary pathologists, which is not a lot. There's less than 3,000 board certified veterinary pathologists in the US, or actually in any country, at least by the ACVP. There are some other organizations. Within that, there is a group who are focused specifically on mouse, but a lot of us have expertise on other lab animals as well. It's called the Comparative Pathology Special Interest Group. And the ACVP does have a committee who talks about pathology errors in research and how people should utilize pathologists or consult with pathologists more frequently. I have to say, they haven't been that great. They talk about it. They haven't been that great at actually reaching out proactively rather than reactively to scientists who might have need of their services. So one of the things that we're trying to do I have a list with me, and this is just a list of some comparative pathology cores that you can feel free to take a photo. I also have them at my poster. If you go to the poster session, I have poster number 42. But we do have a list of comparative pathology core facilities, and I'm pushing through the ACVP. So ACVP is our central entity, through their website to have sort of an Ask the Expert section. So where we could direct scientists to the ACVP, go to that section for Ask the Expert, see if there's a core facility near you. Many of these core facilities, all the ones on my list, take external submissions, and you know, we can take digital slides or just like a phone consult, show me what you have. But it's unrealistic to expect that everyone's going to be able to have a pathologist as part of their team. But one of the reasons for this session and one of the reasons for my participation in ABRF is to build a better bridge between that or between this organization, ABRF, and entities like the ACVP. So I'm pushing through the ACVP to hopefully get this list on the website. In the absence of that, in the interim, I'm giving you as an attendee this list here. And then the other thing I would say, in academic institutions, sometimes if you contact your attending veterinarian, they may not have a core facility there, but they may be able to put you in touch with veterinary pathologists at other institutions. And then the other resource is veterinary schools. Not all veterinary pathologists specialize in mouse pathology, but most veterinary schools have a pathology department and at least have board-certified pathologists there who, if they themselves do not have the expertise to work with research models, it's such a small field, everybody in pathology knows everybody else. They can usually direct you to someone who can help. So I would say, eventually, I hope to be able to just say, go to the ACVP and look at our Ask the Experts. That's what I'm working towards. But in the interim, I would work through your institution, like if you have an attending veterinarian, if you have a facility like Kent's that's geared towards transgenic mice, and also the veterinary schools. That's kind of where you'll find us.
Go ahead, Kent.
Yeah, I hope you're hearing that the specialty of comparative pathology is really, really important. Not to diss on anyone, but sometimes MD pathologists, forgive me if there's any MD pathologists or MDs in the room, sometimes they're called upon to evaluate animal pathology from an experiment, let's say a mouse or a rat or so on. And in most cases, I think I can make this statement, in most cases, they have not received the kind of training necessary in order to interpret pathology in anything other than a human. And so if you employ a human pathologist to help you with your animal pathology needs, just ask clarifying questions about, have they, to what extent are they familiar with, let's say, a mouse or a rat or this disease in an animal model. It's to your benefit because you don't want to be, sent down a path that could be a malinterpretation of what they're looking at. I'm trying to be very politically correct here, right? Now, with all due respect to everyone, I think there's an issue there with veterinary pathology too, because there are, in veterinary schools today, unlike in many years ago, there's much less in terms of training veterinarians and veterinary pathologists to be comparative, whereas more than 100 years ago, that's how this all started. Human medicine, human and veterinary medicine were together. Virchow and, comparative pathology was just by definition, that's the way you taught medicine. And roll it up to 30 years ago, there were a number of fantastic comparative pathologists around the country. But from what I've seen, many, if not most of them, have retired and have not been replaced, with the exception of a few. And you should be asking, if you go to your veterinary school or veterinary pathologist, you should be asking those same kind of questions too. What do you know about, especially if it's a project that has a translational research component, meaning translation to human, as a human model, let's say, or a human model of mechanism, human disease. Make sure you're satisfied that they have sufficient background experience and knowledge of the human condition so they can provide you that real comparative expertise. And then it goes beyond pathology. Now we have all these other omic technologies, comparative genomics, comparative metabolomics, comparative everything, right? So it's exciting, it's wonderful, it's fascinating, but I think we've not done a very good job of training the type of people we need. And then lastly, I'll get off my soapbox, I think this is the basis for why NAMs are becoming so attractive. Because if you think about it, the complaint about animal models and research is that you've all heard the figure 90% of animal models fail to have any human relevance. Well, they're talking mostly about drug testing, right? Which is very, I mean, it's an important, but it's a relatively small aspect of research using animals. And if you have experiments that are not properly designed in the beginning, having a statistician, having a pathologist, another thing, and then if you have those who are interpreting your experience at the other end without the appropriate experience, comparative pathology, you can understand where there could be some misleading interpretation and outcomes of those experiments. And if there aren't the comparative pathologists there trained to help people, or if they're not advertising their availability, then people are going to become disillusioned and they're going to say, well, let's go to something else that's better. To me, that's the origin of this current NAM craze that's going on. I think it's misguided, it's misdirected, it's potentially dangerous, it's being pursued by those at the highest levels of our government. And I think it's important that if we don't want that to happen, we got to start, from the ground up. If you have students who are in veterinary school and they want to be pathologists and they want to be in research, encourage them to be comparative pathologists and get that kind of training and so on. And also as users and as core directors, you hold people responsible too. Make sure that they have the expertise that you need to help your clients.
Just really quick, and I want Ingrid, because I think that's the whole part of it. Kent hit the nail on the head is what we want to get the message out, that we can have these better models and that mimic everything. But just going to your question too, I mean, there's these resources, but in the core, one thing that I try to do is most people come to us if they're new to using the core and consult with us. So we can start there as any member of the core to say, let's get these people involved, right? Let's make sure that this is the right design. So I think that's on us to educate anyone coming in. Now, of course, we have return users. And again, I always, I don't know, there's probably better phrases, but I always think we can, lead the horse to water, but not make them drink it. So that we can do our best, but hopefully we can give more examples like this to show them. I think, Ingrid, you had another good example where people designed the experiment completely wrong, and it was like an animal, wasn't it an animal study that then was like in the clinic, you guys then went back and looked?
I don't know, I have many examples.
Okay, yeah. So yeah, I think it's kind of on us, right, in the cores. So are you in an animal core?
Yeah, I'm with the UW Histology and Imaging core, so we're up there on the list.
Yeah, okay, yeah, with Amanda, yes. So yeah, she's the other one that I call the unicorn that's been here, right? So anyway, I think that you can do that in histology too. That's what I made my manager of the histology group come in, because they can also start spreading that message.
I was thinking, as Kent was talking about how to consult experts and how you have to query your expert as well and provide information to them. This is something that's kind of dear to my heart as well, because a lot of times what happens, obviously we all care about rigor and bias, and we want to avoid rigor and bias. The blinded pathologist, which is really funny. I don't know how you're supposed to look at slides if you're blind, but blinding comes up a lot. And very often, not so much anymore, because we sort of structured our submissions so that we get information. a lot of times scientists will go to a pathologist, MD pathologist, veterinary pathologist, whatever, for their study and just give you slides with no context, no nothing, just tissue from a mouse, like taking a board exam. And they're doing that. I understand why they're doing it, because they want to avoid bias. Maybe they're testing a hypothesis, group A versus group B, and they don't want to bias me in any way. But I basically refuse to read them anymore, because one thing that is important is that context. Because it is a biologic system, there are things that are just kind of background, and you need to know what level of, like, do I need to count something? Do I need to measure area? Or am I just looking broadly for pathology? So when you're talking to a pathologist as a scientist, you want to give them the context of your experiment. So whenever I talk with an investigator, the first thing I ask them is, what is the thing that you're studying? What is the question you're trying to answer? They give me the context. They give me the rest of the experiment. Here's the data that we have. Here is the question that we're looking at pathology for. One that tells me whether or not I can help them. Maybe pathology is not even the right readout for them. And it gives me context. If you want to keep me blinded to sample identity, and if that fits the purpose of the experiment, then that's good. But I'm not operating completely in a vacuum. And I'm not applying, like in that case for scoring, I'm not applying an irrelevant scoring system to your disease. So we basically won't take submissions if you're not going to tell me anything. And we spend, like I said, a lot of time asking, what is the purpose of your study? So if you're coming back with an answer like, just look for pathology, like my old colleague, he got so sick of people just saying, I just want you to look for pathology. He said he was going to send them reports back that had a checkbox. Yes, is there pathology? Yes, no. Because that's the equivalent of what people are telling us. And so whether you're working with a biologist, an MD pathologist, a veterinary pathologist, frame the question and then decide whether a blinded or an unblinded read would work better. And briefly, I'll tell you that there is purpose in both styles of investigation. A blinded read is for hypothesis testing. It works well when you have a defined model, you have an expected readout, I don't know, DSS colitis, you know what the important thing is that you're measuring, and you don't want to be biased by knowing which is the test group, and you're just scoring the thing that you know. If you have a genetically engineered mouse and you're comparing a transgenic mouse to a wild type, if you have a new model where you have no idea what the readouts are, blinding will hurt you, because you need to do a close comparison to the control in order to figure out what's even important. So you're actually hurting yourself by robbing yourself of information if you do a blinded read out of like a kind of misapplied attempt at rigor.
Other questions?
So I'm a breast cancer researcher, and I've made a lot of genetically engineered mice. And for us, we've had this privilege of having Robert Carta from UC Davis work with, and he's a pioneer really in the field of comparative pathobiology. My question, and we've also, once we moved to Utah, we've relied actually on physicians and pathologists to look at our slides, and there are huge issues with interpretation of the data that we provide to them. So my question is, what do we do to fix this issue? How do we fix it? There's less people going into comparative pathobiology now. There's the NAMS, which is probably also going to reduce the number of people that are interested in that field, possibly. Do we train, MD pathologists in this field, or do we train, vets to do this as well? What's the solution here, I guess?
Yeah, yes to everything. I will tell you, I was just speaking to Bob last week. He's doing well. I mean, he must be in his 90s, but he's doing well. I'll tell him that I heard his name mentioned at the meeting. But from my perspective, if we believe in what we're doing, and meaning if we believe that animal models have a role to play in understanding in vivo physiology and pathobiology, and that they cannot be replaced by a novel alternative methodology, then it's up to us to make these changes. And as I've said before, um, the call for more training of comparative pathologists was made very, very loud at the same time that the number of knockout mouse models were being generated. There were the COMP project, the UCOMP project, the NORCOM project, and the Asian market was all starting to produce thousands of knockout models. And at that time, the comparative pathologists at the time said, look, all these mice are being made, and there's not enough of us to interpret them and read them and help guide how we use them. And even in that context, the NIH reduced the funding for training veterinary pathologists in comparative pathology. So we have a big problem. And so what's the solution? Training medical pathologists to be trained in comparative pathology? Sure. Veterinary pathologists? Absolutely. To me, and again, I'm not a pathologist, but it seems there's nothing wrong by looking at lessons we've learned from more than 100 years ago that this system worked. Understanding biology between humans is just another animal. And in fact, as a veterinarian, as a veterinary clinician who's also a PhD scientist, you're better trained than just about anyone to do research. You have the medical training from your veterinary school. You have the clinical training from your residency and practice. And you have scientific training from doing a PhD. I mean, you're a triple threat, right? Whereas in the MD world, they only work on one animal species. That's the human. So yes, it is up to us to make these changes. Training is absolutely essential. That's number one. Number two is I think we need to also counsel. We're core directors. I assume most of these people in the room here are directors. You need to counsel your clients in good experimental design. And if you're a little rusty on the scientific method and experimental design, then you need to beef up your own knowledge in that area because they're going to look to you for your expertise. They have the blinders on and very focused on what they want, and their goal is to get that paper out, right? You need to provide some context, you need to provide some reality, and real guidance in terms of how they should do things better. So make sure they're designing experiments correctly. Make sure they're bringing the statistician, bringing the pathologist early. And then three, whenever you get an opportunity, there was a recent survey of the general public. I think it was published in, I can't remember. I read about it in the New York Times. But the general public wants scientists to speak out more in public about what they do. They want to hear what we do. But we're generally introverted type of people, so we don't like doing that. So we have to get out of our comfort zone and get out there and speak in the general public and explain to them what we do and why it's in their interest and why you're doing what you're doing. And then fourthly and lastly, again, I'll get off my soapbox, I'm sorry about this. Trust yourself, trust your instincts. You are hearing things now which make no sense from people who are supposed to be leaders. And they're talking about science in terms of change your diet and you'll cure, I don't know, what was it today? Parkinsonism or schizophrenia or something. Be mindful of vaccines because they could still be causing all. So it's important when you hear things like that, speak out and speak up. The general public is relying on us as scientists to be able to call them on it and say that this is wrong. And I think it's a hard thing to do. It takes courage, but I think we need to do that.
Just to try to add on some to that. So there's sort of two levels of looking at any problem in science in terms of supply of it. There's kind of the big picture and there's like what we can do today. And I think, so I've already talked about some things like making it more known, having centralized access to lists of experts, people you can consult. But I think there's also opportunity to train biomedical scientists, people who already have expertise in histology, just about those basic concepts that I talked about Like, I mean, for 16 years now, I've taught pathology for non-pathologists, and I joked about my all of pathology in one slide thing. But that framework, I think if you understand that it's a continuum, that the body's like injuring, responding, even if you don't have like all the different pathology gibberish names at your fingertips, if you understand that basic process and the basic process of disease as it appears morphologically in the body, that's not that hard a concept to teach. I could teach it to you in, I don't know, a pathology session or two. And if you have that basic concept, it helps you as a histology core person or as a basic biomedical scientist think more broadly and interpret your own data and the data of others more correctly, because you understand that inflammation, there's different phases of it. There's an inflammatory response to tissue injury. You can interpret better rather than my conception back in veterinary school, where I thought every disease had one pathologic output, which was incorrect. But that concept, that idea that every pathology disease has one morphology is still pretty widespread, even among scientists, strange to say. So I think we could do things like have educational seminars like pathology for the non-pathologist in biomedical research at meetings like this, at other meetings. There is a mouse pathology workshop that was taught for general biomedical and veterinarians, but general biomedical scientists for many years at the Jackson Lab. That's now, the grant for it has been taken over by St. Jude Children's Research Hospital. Jennifer is going to be speaking at this meeting next month. So every April, there's a mouse pathology workshop that comes out of that Jackson Lab tradition, which is exactly that. It's kind of an introduction to pathology for the non-pathologist. And I don't feel like we as the pathologists have to be the gatekeepers, like no one can read the slides but us. I think you just need the context. And I mean, in my master's degree at MIT, I had a pathology project. I was reading slides way before I became a pathologist, because someone took the time to explain to me the context of what it was that I was measuring. So I think education for pathology education for biomedical scientists and for core facility people will go a long way towards at least setting that mindset, setting that framework, that you're not just trying to match, here's the human, here's the mouse. These two things have to be exactly equal. That's not really what it is. You're thinking of, you have a better understanding of how disease works in the body. I think that's a fundamental part of being a good, broad biomedical scientist. So that's one thing that I look forward to, is more seminars like that just kind of education for a broader audience.
Do you know
can I
if-
say one more thing?
yeah.
Sorry. And then we're going to, so the bottom bullet here, so these are just some other references that I put for people who attend this meeting to take away. Some of them are related just pretty practically to tissue trimming. The world of toxicologic pathology, which is kind of its own universe, but a lot of veterinary pathologists work in toxpath and pharma, they've done a great job at standardizing. So I use a lot, my background is in toxicology, I use a lot of the toxpath guidelines for trimming, and importantly, at the very bottom where it says animal pathology terminology and diagnostic criteria. Anybody heard of InHand? So InHand, yay, somebody in the back. So InHand has a long name, International Harmonization of Nomenclature and Diagnostic Criteria. This was first put together by pharmaceutical companies broadly, like internationally, to standardize the nomenclature, so that when you're submitting a report to the FDA, we're not using, as pathologists, different words to mean the same thing. So there's some beautiful in-hand guidelines for what are the criteria that it takes to diagnose, I don't know, hyperplasia in the liver or inflammation in the liver. And the beautiful thing about ToxPath, it uses a descriptive terminology that's very easy for the non-expert to understand. So in diagnostic pathology, we say hepatitis because that has a clinical connotation. In ToxPath, and I would advocate in biomedical research,